Welcome to the Oasis-E webinar and AllHomeCaring training seminar, presented by Gregory Wilkerson.
Oasis-E is a transition that we're going to have to go through in January 1st, 2023. So we'll no longer be charting in Oasis D1 anymore. And this is something that happens every few years with Medicare. They update the Oasis and have us collect some different data sets. So welcome and thank you for joining today on our seminar for Oasis-E. My name is Greg Wilkerson. I'm a registered nurse in the ADON with AllHomeCaring in Florida. We're going to hold all questions until the end. If you have any questions, if you're on the live presentation, you can type them in the chat box or we'll unmute the folks at the end in order to allow for a Q&A session. If you're not joining live but rather viewing this after the fact, please feel free to contact your administrators. Go ahead and take notes during the training seminar, and then at the end, if you do have any questions that come up, you can always ask your ADON or your DON. So our objectives for today are to be able to identify the differences between Oasis D1 and Oasis-E, to understand the new items for behavioral health and health information, and to be able to understand why these new items are being introduced. So the reason why Oasis is what it is and being updated every few years is because of the Post-Acute Care Act, or the IMPACT Act of 2014. And the idea with that was for standardization of post-acute care data to improve Medicare beneficiary outcomes through shared decision-making, care coordination, and enhanced discharge planning. The CMS meaningful measure priority areas are to promote effective communication and coordination of care, to promote effective prevention and treatment of chronic disease, to work with communities to provide best practices of healthy living, to make care affordable, and to make it safer by reducing harm, costs, and delivery of care, to strengthen in-person and family engagement as partners in their care. Resource use and other measures domains. Resource use measures include the total estimated Medicare spending per beneficiary, discharge community, and all condition risk adjusted, potentially preventable hospital admission rates. In our next slide, we have our administrative burdens. For a start of care on the first row, in Oasis D1, there's going to be 158 items that were used. For Oasis-E, they've added 59 items, and they've removed 14, so there's a net change of 45, for a total of 203 with the new assessment. CMS estimates that the charting alone is going to take 57.3 minutes on a start of care. For a resumption of care, we have 131 items in the past. They've added 49 items, taken away 8. There's a net change of 41 there, and a total of 172 codified items, and 48 minutes is going to be the estimated time from CMS for that assessment. For follow-up assessment, they're estimating minutes, and so on and so forth as you go down the line. So what's different with Oasis-E? They've added items in 3 categories. The first being standardized patient assessment data elements, or SPADES. There's a new brief interview for mental status, or BIMS assessment, and they're looking at now social determinants of health. There's also been an elimination of items that don't meet the criteria for inclusion. Now, they've added quite a few new things, and they've taken away just a small handful. In order to be included as an Oasis item, the data set has to one or more of the 4 criteria listed below. Either calculate a measure for the home health quality reporting program, contribute to the calculation of payment, be used in the Medicare survey process, and or be used to calculate a measure in Care Compare. Oasis-E notable differences. So, in the past, there could be a bit of variation from one software provider to another, as long as all the items were included. However, Medicare is now standardizing the formatting, so there's going to be less differences from one software provider to another. This can be advantageous in order to make communication a little between different organizations that have to share information Also, if a clinician works for multiple agencies, this should help decrease the burden in trying to remember the process for different software providers and charting in them. The items that we're familiar with are going to be sequenced differently. They're breaking it up a bit differently. We'll get to that in a little more detail as we move along. Some of the items have been separated. For example, race and ethnicity was one item before. Now it's two separate questions. In the revised Oasis-E draft, patient declines to respond was added as an option for social determinants of health. So that's good. Sometimes someone may not want to respond to certain questions, and if that's the case, we're not pigeonholed into answering a question on their behalf if they want to withhold that information. We have ethnicity, race, transportation, health literacy, and social isolation. Those are the social determinants of health items. So our sections of the new Oasis-E. A is administrative. Those are our demographics, basic information. That's familiar, but now it's under A. B is going to be for hearing, speech, and vision. C for cognitive patterns. D for mood. E for behavior. F, preferences for customary routine activities. G are functional status, and GG are functional abilities. That is something that we're already familiar with. That hasn't really changed. That's something that was new with Oasis-D. So that's now has a place, and there was a method of the madness with naming them with a seemingly random number, or rather letter of GG. H is going to be our bowel and bladder assessment. I, active diagnoses, and where that came much earlier on in the past, typically, it's going to be further down in the assessment now. J is for health conditions. K for swallowing and nutritional status. M will be for skin conditions. The N section will be medications. O for special treatments, procedures, and programs. Q is patient assessment and goal setting. Now, I want you guys to note that the L and P sections are not in yet, at least, so we can anticipate perhaps in the future they may be used for some sort of new assessment data set. What those will be, or if that will even be, it's anyone's guess. So we're going to get into a comparison between the old and the new, Oasis-D1 versus Oasis-E, over the next few slides. So whereas in the past, Oasis-D1, we had patient tracking, clinical record items, patient history and diagnosis, living arrangement, sensory status, integumentary, respiratory status, and elimination status. The column on the right, you'll see now we have A, administrative information, B, hearing, speech, and vision, C, cognitive, D, mood, E, behavior, F, preferences for customary routine activities, G, functional status, and GG, functional abilities and goals. Oasis-D1, we had neuro, emotional, behavioral status, ADLs, medications, care management, therapy needed, emergent care, discharge, functional abilities and goals, and health conditions. In Oasis-E, we have H, bowel and bladder, I, active diagnosis, J, health conditions, K, swallowing, M, skin conditions and medications, O, treatments, procedures, programs, and Q, participation and assessment. And comparing items added to items deleted. New items added will be on the left, items deleted on the right. We have now ethnicity as one of the A, race, A, language, and this is going to be the patient's preferred language rather than what they necessarily speak. So if they speak English quite well, but they prefer to speak Spanish, we're going to answer Spanish even though they do speak English well. Again, this is the patient's preferred language, maybe not necessarily what they're fluent in. Transportation, provisions of current reconciled medications to subsequent provider on any transfer, and also on discharges. And whereas in the past, the route of current medication reconciliation lists, let me back up a moment. We have the route of current reconciled medication list, transmission to subsequent providers. Items deleted were the race and ethnicity. Added, we have a provision of current reconciliation medication lists to patient at discharge. and again on a transfer. We have a hearing, vision, health literacy, questions on the BIMS, repetition of 3 words as part of the BIMS, temporal orientation, we have a question for recall, BIMS summary score, this is all part of a assessment for delirium, and signs and symptoms of delirium. Deleted were therapies received at home, the pneumonia vaccine, and a reason for the pneumonia vaccine as well. Added was a PHQ-9 screening instead of PHQ-2. There's a total severity score. Social isolation question, a pain interference with therapy activities question, pain interference with day-to-day activities, nutritional approaches, high-risk drug classes, use and indications, whereas in the past we just answered if the patient had any high-risk drugs and if we educated on it. Now we do need to also indicate the use for those and their indications and what those classes are. So a little more detailed assessment on that. Special treatments, procedures, and program screening. Deleted was of pain interfering question, pain effect on sleep, depression, patient caregiver drug education intervention, and intervention synopsis for diabetic foot care. So our first section A, administrative, will go over each of these. So all of the demographic information that hasn't really changed, that's all the same. That looks familiar. Again, but race and ethnicity, that has now been split up into 2 separate questions. The question now on transportation. The patient's, now this isn't necessarily transportation to go on a vacation. This is in relation to a patient's ability to get to doctor's appointments or medical tests, to get their supplies that they need, their basics, their groceries, things of that sort. And this is really an important indicator of someone's state of well-being, with whether or not they can actually get to where they need to go. And whereas in the past, this maybe was not in the assessment, may have been something we were asking if we were keen, it's now part of the Oasis assessment, so this is good. Next part of the administrative section is our reconciliation of medications. This is new. The other items are familiar already, but if you look towards the bottom where the star is, and the star is going to indicate throughout the presentation any new items. So now we do need to not only reconcile the patient's medications, but also document how that list is given to the patient, how it was given to the patient's providers. And not only that we did it, but how we transmitted those, whether it's through a printout, through mail, through giving someone a CD, through faxing it, so on and so forth. So this slide is showing just those mentioned items, how those medication reconciliations are being transmitted. And I don't know anyone that sends CDs anymore unless it's maybe a radiology file, but hey, that's an option on there. So in the past, we reconciled patients' medications on a starter care. If they went into the hospital and came out and things changed and we did a ROC. Now we're expected to also reconcile medications at discharge. Why do they want us to do this? To ensure that new caregivers or the patient and family are aware of their current medications, doses, and reasons. We're not involved in their care anymore. Now they need to manage that. They need to have that. So that's an important thing when we discharge a patient from home care. So make sure that those are reconciled. Just as when somebody leaves the hospital and they receive a list of their medications when they're discharged. It's also important when they're discharged from home care for any of the same reasons. And medication reconciliation should be an ongoing process rather than just a single process that we do at the start of care. As people's medications are something that is an ongoing thing. It is a living thing that changes and morphs as time goes on. Medications are increased, decreased, discontinued, new ones are added, so on and so forth. And when you consider that medical errors and medications are implicated as the third leading cause of death, it's understandable to see why there's more and more emphasis as time goes on proper reconciliation of medications. We really do have an important role as healthcare providers in keeping folks safe and preventing injury and illness. And the medications is important, so it's not something to just brush over. Section B is hearing, speech, and vision. So what was removed was the sensory status question. And now we have separate questions on hearing and vision. We have a new question on health literacy. And the question reads, how often do you need to have someone help you read instructions, pamphlets, or other written material from your doctor, your pharmacy? And it's a spectrum, anywhere from never to patients unable to respond, or they always have to have somebody, or they can even decline to respond. So personal health literacy, what is it? It's defined as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. The new definition emphasizes people's ability to use health information rather than to just understand it. So implementing information is a whole nother thing versus just comprehending it and moving on. Focus on the ability to make well-informed decisions rather than just appropriate ones. And when you think about the cornerstone of medical ethics, it is informed consent. That is really important. So is somebody making a decision just based off of a limited amount of information, or are they truly informed and have all of the information that they need to make a really good informed decision? Acknowledge that organizations have a responsibility to address health literacy. So we as healthcare providers do play a role in that. It's not good enough to just hand somebody a pamphlet. You could train a monkey to do that. Anybody can just give out the information. As healthcare providers, it's really important that we make sure that our patients understand the information that's being provided to them and are able to implement it. And if they have any barriers to understanding it, we do have a responsibility to help them overcome those barriers in order to better implement healthcare information and make better decisions to improve outcomes for their health. And this really does come from a public health perspective. So it affects all of us. It's not just an individual problem. If somebody has an issue with health literacy, we're all in this together. It's something that we do need to really educate and help improve. And our role as nurses and other healthcare providers is as patient advocates. And advocacy starts with education. Section C is our cognitive assessment now. So the first question in this is asking the patient to remember 3 words that you're going to say. The 3 words are sock, blue, and bed. Now tell me these 3 words. And this is on the first try only. There can't be any prompting. The spouse can't answer for the patient. And if they get it after multiple tries, well, that doesn't count. So if they say sock, blue, and I know it was a piece of furniture, it was a chair. Oh no, it was a bed. That doesn't count. They have to get it on the first try. And then we're going to code whether they got none, 1, 2, or all 3 of those correct. Now, after the patient's first attempt, if they do stumble and have difficulty, we can repeat the words using cues. Sock, for example, something to wear. Blue, which is a color. Bed, which is a piece of furniture. You can repeat the words up to 2 more times. They can have a second attempt, and there's a question for that. The next section is temporal orientation in C. So we're looking at orientation to year, month, and day. So we're going to ask the patient, tell me, what year is it right now? And we're going to codify if they're able to report the correct year, or if they missed it by a year, if they missed it by a few years, or if they missed it by several years. Then the patient, we're going to ask them, what month are we in right now? And again, it's going to be, the answers are codified by just how accurate they were. And finally, what week is it, or what day of the week rather is it today? And that one, either they get it correct or incorrect. It's not you're a few days off or you're 1 day off. It's either you know what day it is or you don't. The CAM, or Confusion Assessment Method, is a standardized evidence-based tool that enables non-psychiatrically trained clinicians to identify and recognize delirium quickly and accurately in both clinical and research settings. The screening tool alerts clinicians to the presence of possible delirium. Included is a link to a video on YouTube on this new assessment and how to implement it. And I do encourage everyone to go ahead and watch that video. It is very helpful. So section D is our mood assessment. So in the past we asked two questions in regards to mood or depression. It was a PHQ2 screening. Now they've upped this, it's the PHQ9 screening, so it's a little more comprehensive. It's the same thing we're used to, just a little more in depth. Also, we have a question on social isolation. How often do you feel socially isolated? And that's a whole range, or the patient can decline to answer. Section E is behavior. So this is a familiar item. This really hasn't changed from the past. We have the cognitive, behavioral, and psychotic symptoms screening, and the frequency of disruptive behavior question. Section F, preferences for customary routine activities. This is the patient's living situation. This is a question that is not new. It's something we're all very familiar with. Whether or not the patient lives alone or with other persons in their home, and how often is assistance available. The next part of this is the types and sources of assistance. And again, that's nothing new. These are all questions that we are familiar with. Sections G and GG are functional and functional ability sections. There's really no changes to the 1A- items except that M1870 moved to a different category, and otherwise there's no changes to the GG item. Section H, bowel and bladder. The elimination status, bowel and bladder questions, these really haven't changed much. They'll be very comfortable and familiar. Section I, active diagnosis. This is something that is not really different, other than that we're no longer going to see this on the research. Section J, health conditions. Our new assessments here are in regards to pain, in regards to how pain interferes with sleep, therapy activities, and day-to-day activities. So whereas in the past this assessment was a little more limited, they're breaking it up into a little more areas to codify how the pain affects the client. Also in this section we have any falls since the most recent starter care ROC. It's the same assessment, it's just what section is it in now, it's different. And our shortness of breath, or M1400 question, is also in this. Section K, swallowing and nutritional status. We have a new question on nutritional approaches now. On that we have parenteral or IV feeding, whether or not they use a feeding tube, if they have a mechanically altered diet, a therapeutic diet, or none of the above. Going to be separated out, whether at the start of care or on discharge, to track if there's been any improvements. The M1870 item on feeding and eating has just been moved to here from the functional items. With section M on skin conditions, there's really only been graphics changes, otherwise nothing's different here. Section N, medications. 2001 and M2030, there's no change except the deletion of M2016. As far as the high-risk drug classes, uses and indications, this has been expanded a bit. So now we're going to codify if the patient is on an anticoagulant, an antipsychotic, antibiotics, so on. And if they're, not only if they're taking these, but also if an indication is noted for this medication. Now we may know what the indication is for, however, that's not what this question is asking. It's asking if that indication is actually noted on the patient's medication list from their provider or on the prescription itself. If it's not, we won't be clicking that second button. So section O, special treatments, procedures, and programs. No longer do we have in the left column therapies patient receives at home, such as total parenteral nutrition, etc. Instead, we have this newest section O assessment for special treatments, procedures, and programs. So, as you can see, we have cancer treatments, whether it's chemo, IV, oral, or other, whether it's radiation therapy, oxygen therapy, continuous, intermittent, or high concentration oxygen, more than 4 liters per minute. And continuous oxygen is identified as anything more than 12 hours per day. Whether they have suctioning, trachea, if they have a mechanical ventilator or a non-invasive ventilator, a CPAP or a BiPAP, IV medications that are vasoactive, antibiotics or anticoagulants or other, transfusions such as dialysis, hemodialysis or peritoneal dialysis. IV access, whether it's a peripheral line, a midline, or a central line, or simply none of the above for hopefully a big majority of the patients. The pneumonia vaccine question, as you can see, that was removed. So we still have the influenza vaccine question. And therapy needed in plan of care, this is the 3-digit number of anticipated therapy visits. Now, for a little bit, this has not gone into factoring the payment. However, for whatever reason, Medicare has not removed this question, so we still have to answer it to the best of our ability. Section Q is participation in assessment and goal setting. The only thing that's really changed with this section, this is familiar, they're removing the diabetic foot education part of this assessment. For what reason, I'm not sure. Diabetic foot care is very important, but CMS isn't really tracking that information going forward. So, now that we've gone over all of these new Oasis-E sections, how things have been changed, added, recategorized, or what items have been deleted, how are these items being used? There's a few different things that all of this funnels into. First of which being a patient-driven groupings model, or PDGM, that we're familiar with. And that's for functional grouping and scoring. There's the Home Health Quality Reporting Program, or HHQ. Homepage when you first log in, if you scroll down to the bottom, there is a section for announcements. And you can find that. If you have any trouble finding that or navigating to it, we can help you out with that. And there's a reference to the Centers for Medicare and Medicaid Oasis-E manual. That's easily found by Googling. You don't necessarily have to write that down, but just so you're aware, that is the URL to find the manual. And again, that's quite a bit of information. It can be quite wordy. So if you do have any questions, please refer to that. And if you still have questions, by all means ask us. We can help you out. If we don't know the answer, we'll find someone that does. So we're going to go ahead and unmute now for anyone that may have any questions that's with us live. If you're watching this through the portal after the fact, go ahead and contact your nursing administration at this time for any questions that you may have.
You sending any chat message?
Bear with us. I have the settings where now any attendee can turn on their microphone, so if there's any questions, please do so and go ahead and ask. I don't see any in the chat box. Actually, I take that back. There are a few. And I don't see any questions specifically. LaKendra, did you have a question?
Yes, can you hear me?
Sure can. LaKendra, go ahead.
Okay, so my question was, when I get ready to go on to do the Oasis-E, is it going to be there? Because I haven't seen it yet. It doesn't start until January, correct?
That's correct. It doesn't.
Okay.
Sorry about that. We're muted now. That should take care of the... So the question was, if anyone didn't hear it, was when I go on, I can't see the Oasis-E yet. Is it correct that won't be available until January 1st? So in the live platform, that's correct. We won't see that change implemented until January 1st. So all charting after January 1st will need to be in the new Oasis-E. Next week, Laura is putting on another seminar where they're going to preview that, or webinar rather, I should say. When you first log into Laura, there's the announcements that come up. Don't just click past those. Go ahead and go to the link there and sign up for that seminar. I also sent out with the information for that, encouraging everyone to attend. I've signed up for it. I'm going to be attending that. And again, please everyone else do so, because that's going to show how it's implementing into Allura. There may be some changes from when they do that presentation to the actual live implementation. And there may be a few bugs to work out, as there is with any. Allura support, thankfully, is very helpful. If you do have any technical issues that come up, we do encourage that you go ahead and contact Allura and let them know so that they can get those bugs fixed. Does that answer your question, LaKendra?
Yes, thank you.
Hey Greg, I just want
Sorry, Jerry, I'm going to I'm going to mute my laptop so you don't get the feedback. Go ahead and try again. Go ahead and unmute yourself and ask again.
And unmute when she's speaking, unmute her.
Alternatively, Jerry, if you could type your question into the chat box. Seems like you're having some technical difficulties on your end with feedback.
Can you hear me now?
I can hear you. Go ahead.
All right, I just wanted to say thank you and tell people to just let us know if they have questions. Laura will handle the transition. At least they always have. Just keep us all informed. Get through this.
Thank you, Jerry. Yeah, it can be a little daunting at first. It's going to slow us down a little bit as we learn how to chart in this new way. But as we always have in the past and always will in the future, we'll get through it, we'll help each other out, we'll figure it out, and before we know it, this is going to be second nature, it's going to be easy. Just know that, yeah, it's going to take a little bit of an adjustment, but it's something that will be easily managed with time and won't be a big deal eventually. Don't get too scared about all of this. It's just part of healthcare and something we have to deal with every few years, that they're going to change it up, and know that that's just the way it is, and it's okay, and that's why we have all these resources. And again, if you do have any questions that come up at any point, need any help with anything, that's why we're here. So please don't hesitate to ask for help. I don't want anyone to feel like they're on their own with this. Any other questions? Looks like we don't have any more questions. So this concludes the Oasis-E training seminar. Thank you for attending.